Hello, welcome to AI Medical School. In this video we are studying connective tissue disease, which is lupus erythematosus. But before starting the video, subscribe to the channel and hit the thumbs up. Connective tissue disease. It's mainly involved connective tissue including multiple organs and systems which belongs to autoimmune disease. Connective tissue disease includes lupus erythematosus, dermatomyositis, scleroderma rheumatoid arthritis, Sjogren's syndrome. Mixed connective tissue diseases are classified as connective tissue diseases. Lupus erythematosus is manifested in many forms and may involve any organ of the body. We classify the specific eruptions of lupus erythematosus in the following way: 1. Chronic cutaneous lupus erythematosus. 2. Subacute cutaneous lupus erythematosus. And 3. Systemic lupus erythematosus. Etiology. Genetic factors play a role in the development of systemic lupus erythematosus. The prevalence of systemic lupus erythematosus in first-degree relatives of systemic lupus erythematosus patients is 1.5%. Systemic lupus erythematosus occurs predominantly in females in the reproductive years. Multiple abnormal immune responses are present, which may be responsible for many of the manifestations. An abnormal response to sunlight, both UVB and UVA. Several aspects of the altered immune response are worth particular attention. The T suppressor cell function is reduced. Overproduction of gamma globulins by B cells causes overresponsiveness to endogenous antigens. Drugs such as hydralazine, sulfonamides, penicillin and minocycline et al. Have precipitated systemic lupus erythematosus. Although many such cases run a relatively benign course, with clearing and recovery within a few weeks or months after discontinuation of the drug, some patients continue to be gravely ill or have repeated relapses and seem to develop true systemic lupus erythematosus. Chronic cutaneous lupus erythematosus. Discoid lupus erythematosus generally occurs in young adults, with women outnumbering men 2:1. The character of discoid lupus erythematosus eruption as follows: dull red macules with adherent scales. Patulous follicles. Removal of the scales shows horny plugs that filled the follicles. Telangiectasia. Some discoid lesions are very superficial, resembling mild seborrheic dermatitis. On the other hand, erythema may be minimal, and the patch is merely hyperkeratotic, dark gray and centrally depressed, suggestive of a solitary lesion of lichen planus or a carcinoma. Very small lesions of discoid lupus erythematosus may be mistaken for actinic keratosis. Localized discoid lupus erythematosus. Concept: discoid lesions are localized above the neck and head. Favored sites: scalp, bridge of the nose, malar areas, low lip and ears. Character of lesions: dull red macules with adherent scales. Patulous follicles. Removal of the scale shows horny plugs that filled the follicles. Telangiectasia. Scalp lesions can be resulted in alopecia. Generalized discoid lupus erythematosus. It is less common than localized discoid lupus erythematosus. Concept: in addition to the usual sites for localized discoid lupus erythematosus, also involve the thorax and upper extremities. The course of discoid lupus erythematosus is variable, but 95% of cases are confined to the skin. Progression from discoid lupus erythematosus to systemic lupus erythematosus is uncommon. Fever may signal its occurrence. Laboratory findings. Abnormal laboratory tests include the elevation of antinuclear antibodies, leukopenia, hematuria or albuminuria. Some cases may progress to systemic lupus erythematosus. Careful evolution should be carried out at regular intervals. If 4 or more criteria for systemic lupus erythematosus are met, one may make the diagnosis of systemic lupus erythematosus. Treatment. General measures are important, such as avoid to sunlight. Use high SPF sunscreen lotion daily. At the same time, the patient should also avoid exposure to excessive cold, to heat and localized trauma. Local therapy. Topical super potent corticosteroids. Small lesions can be injected corticosteroids into the lesions. Triamcinolone is infiltrated into the lesion every 1 week. Continue to use for 4 to 6 weeks. Systemic therapy. The safest and most beneficial systemic therapy is antimalarials. Hydroxychloroquine is used first because of its safety. Systemic therapy may be necessary during the summer, but often can be reduced or stopped during the winter. Relapses are common even with the antimalarials, and long-term therapy is frequently necessary. Patients should be watched closely for possible side effects, especially ocular toxicity. The finding of any visual field defect is an indication to stop antimalarial therapy. Other side effects include nausea, vomiting, diarrhea. Systemic corticosteroids for widespread are effective. However, treatment should be limited. Other therapeutic drugs have dapsone, thalidomide, Prognosis. Most cases are better prognosis. Only small may progress to subacute cutaneous lupus erythematosus or systemic lupus erythematosus and involve organs. I hope you liked the video. Thanks for watching.